Alright, maternal, newborn, and nursing. We're going to study chapters 1 and 2 today. So beginning with chapter 1. During the past 100 years, maternity nursing has gone numerous changes, and huge changes as well. We have a history from all the way back to the 1600s to the present age. You know, in the 1600s, it was the first invention of forceps, the first time they actually used instruments to go in and extract the baby. Next, in 1615, we had the very first C-section. They actually went in and cut the baby out. 1650, Legat discovered fetal heart tones. First time that they realized, oh, this baby has a heart of its own. Next, they discovered that the fetus had its own blood circulation. From there, we went to 1843, and all of a sudden we decided, hey, it might be a good idea to wash our hands. See, the story goes that the doctors were going in and doing autopsies, and right after an autopsy on this dead person, they would go and deliver a baby without washing their hands. I know we're completely disgusted by that and thinking, how could they not know? But they just didn't know. It wasn't the practice then. So they started kind of washing their hands and developing this germ theory. So in 1844, they realized antiseptic surgery. This might be the answer to all these people getting sick and dying from our surgeries. They realized that like midwives and people having babies at home weren't getting quite as sick as the patients who were in the hospitals, and they said, what in the world is going on? So once they started kind of washing their hands, they had better results, and people weren't quite as scared to come into the hospitals. In the 1900s, most babies were completely born at home. You had the midwives, you had just a bunch of babies being born, and moms back then were super tough and would just like push them out and then go cook dinner. You know, it was amazing. 1920s, they discovered this thing called twilight sleep. And what it was just kind of a concoction of medications to help ease the pain of childbirth. At the time, it was only for the wealthy, those who could actually afford it. But after they started kind of doing this and realizing how much easier it made childbirth, they decided we should kind of start bringing childbirth back into the hospital and helping with the pain management. So about the time of 1950s, that's when people really started coming to the hospitals to have their babies. 1970s, no men were in the delivery room. It was strictly a woman's thing. Men just weren't seen. They would be outside smoking in the halls of the hospital, you know, waiting for the baby to come, and then they would go in to see them. And so you can see where currently that's completely changed. One, we don't have any smoking in the hospital, but also men are right there, a part of the birthing process. We encourage them to be a part of the birthing process. We encourage the whole family to be a part of the birthing process. A lot of times you'll have at least 2 members of your family in the birthing room as that's taking place. So you can see a huge change has happened, and the current trend is that we're trying to manage labor and birth through induction and cesarean births. And we'll have 2 articles that I want you to read, and you'll do a discussion board, but we'll talk more about that in class. But what we're currently seeing a lot of is trying to go ahead and induce because this date works for me best, or my doctor's going to be out of town, so let's go ahead and plan to have the baby here. I've had 2 sections in the past. I'd really like to plan it here so I get more vacation time. You'll see a lot of that, and we'll talk more about that in class as well. So we're having changing concepts. Maternity care, it's more specialized now. We have obstetricians, neonatalists, child health care, doctors who are specializing in women's care, in just the baby, the neonatalists, when the baby's out, just having a special doctor only for the baby. And then, of course, having their pediatricians following throughout. Again, you see the family-centered care more now. Husbands are encouraged at the birth. We have birthing rooms, labor and delivery rooms, labor, delivery, recovery, and postpartum rooms. We want to encourage that bonding initially, putting the newborn on the mother's breast right after the baby's born and encouraging that bonding. Children are viewed as part of the family. They're allowed to come in and see their new baby brother or baby sister. And the child and the family are viewed as the patient. We address their emotional, their developmental, social, and scholastic needs. Regionalized care, this is a trend that is kind of taking place towards centralized location of care. And what that's saying is that a lot of times right here in Amarillo, we are a small center of this, where a lot of the smaller communities will come from Dumas and Borger and Pampa and Wheeler. They'll come and they'll get their services here. But even more so is because of all the specialties that are taking place, because of diagnostic tests and things like that, we are able to see what's going on with that baby, that neonate, early on, and we can see if that baby has a congenital heart defect or something along those lines. And so if the baby does, instead of delivering the baby here in Amarillo, Texas, we'll say, you need to go on down to Cooks, you need to go down to Fort Worth, Dallas area, and have the baby there. We can schedule a C-section down there, and then the baby can go straight to the neonatal intensive care unit, and from there we can go and we can do surgery. So rather than have a big hospital bill here in Amarillo and then an ambulance bill and all of those things, we're trying to make it where it's just one spot. Okay, problems with that, it's usually far from home, and of course the reasons we do it is to avoid the duplication of services. They have all the specialties available there. Of course, being far from home, it can be very traumatic and stressful for the family. Advances in researches. Now this is kind of where it goes into certain issues of how good is technology? How far can we take technology? You know, we have the prenatal testing, which will show us any kind of abnormal chromosomes, any kind of defect this child might have. But we can see that early in advance. And so a lot of times the parents will be asked, do you want this testing done? And sometimes they'll completely refuse it, and other times they'll say, yeah, I think it would be beneficial. But what are you going to do with those results? What are you going to do if you find out that you have a baby with Down syndrome? The problem is sometimes it gives you the option to abort that baby. But are we playing with this delicacy of life? And are we going too far with that? The Human Genome Project is something that was started several years back, and we finally got it just now completed. It was started in the 1990s. It was completed in 2013. 2003. It was a 13-year project, but we're still having research come about it. And what that is that it's identifying carriers of genetic disorders, those at-risk babies. So that's a big part of that, and like I said, it's just how much research is good. How much do we really want to do, and how much are we able to play with? You know, it's kind of the pro-choice or pro-life. And what you're going to find in OBGYN and in our class, we're going to go through a lot of ethical decisions. You're going to see a lot of ethical issues come up in this because there's so many ethical issues in here. You know, you've got the pro-choice and pro-life, which is a huge issue in and of itself, but you also have who has the right? Does the baby have the right? Does the parents have the right? Or does the hospital have the right? So we're going to discuss those things. We're going to go through those things and kind of walk through it and see what's the right answer or what's the wrong answer. Or maybe that's why it's such an ethical decision, is because there isn't a right or a wrong answer. So we'll talk about that as well. Demographic trends, aging of the population, growing minority populations. You've got poverty greatly influencing maternity and pediatric care. Were they able to do prenatal care, or are they coming in straight off the streets, 42 weeks pregnant, you know, about to have this baby? It can have a huge negative impact on them. And so what we try and do is we try and give everybody an opportunity to do prenatal care. You know, we want them to be adequately nourished and sheltered. That's going to obviously put that child and that mother at a huge advantage versus just coming straight off the streets, not knowing if they have any prenatal care at all. health disparities, consequences of health disparities, and barriers to access care. So we're trying to make it where everyone has access to health care. Again, ethical decision, which we'll talk more in detail in class, is health care a right or is it a privilege? And I want you to really, really think about that and go on both sides of it, kind of step aside and say, well, this is why I think it should be a right. This is why I think it is a privilege. And just kind of play through those things. Make a list, pros and cons. Is it a right? Is it a privilege? And bring that to class and we'll discuss those things. That's something, honestly, that you will carry with you in your career. And I don't know that you'll ever find the right answer to that. Cost containment, I'm not going to go into this and say a whole lot about this, but just be careful about how many towels you bring into a room. Everything gets priced and everything has a price for it. Even a wash rag, you're thinking, really a wash rag? Yes, because someone has to do the laundry. And like I said, we're not going to go into that. Just be careful about how much that excess you take in. You don't need 3 bars of soap. They probably already have soap in there. Go in the room, check it out before you go in there, and make sure that you're not taking in too much or doubling up on expenses. Like I said, that's all we're saying about that. Okay, so we have evidence-based practice. And evidence-based practice is the integration of the best research evidence, clinical expertise, patient values, and making decisions about the care for the patients. So a lot of times there's hospitals that will only work on evidence-based practice. Northwest is one of those hospitals. An example of evidence-based practice is Foley catheters. They used to always irrigate the Foley catheter, but then they started realizing that when you did that, you were causing UTIs. So because of evidence-based practice, we no longer irrigate Foley catheters. Okay, payment for health insurances or payment for health services. You've got your private insurances, you've got those federally funded services, Medicaid, Social Security, block grants to states. Often applying is very complicated, it's confusing. If you've ever done it before, you understand the frustration there. There's also child care health insurance programs. And you can just read through those and you'll see them as you start practicing. You'll be able to recognize them a little bit more. Okay? Special supplement nutritional program for women, infants, and children. Okay, so you're going to hear a lot about the WIC program, and we're going to refer patients to the WIC programs. It's a really good program, and their goal is to improve the nutritional status for the women and children. So anytime you go shopping, you'll see little signs that say WIC approved. They've made it now where it's very easy to kind of even hide or disclose that they're using the WIC program. They have food cards that look just like a debit card. The purpose of it is also to serve those low-income people, families, nutritionally at-risk pregnant women, breastfeeding moms, postpartum women, and their children up to 5 years of age. You must meet income eligibility requirements, and then eligible women and their children receive food vouchers to redeem at participating grocery stores. Like I said, now it's almost like a debit card. You don't even know really who's doing WIC and who's not. So it's more comfortable for those women to access that now. They're not quite as embarrassed, and it shouldn't ever be something that you're embarrassed about, but at the same time, everyone's different about taking a little bit of charity. So anyways, moving on. Specialized services, we have the Shriners Hospital for Children. The services are completely free. A lot of times they'll do orthopedic disorders, burns, spinal cord injuries, cleft lip, palate. No eligibility is required. Early Childhood Intervention Program. It's sponsored by Easter Seals, serving children with disabilities or developmental delays. They'll have evaluation and weekly therapy for rehab, and referral comes from the healthcare provider. Maternal child health today. Okay, so the CDC tracks maternal, infant, and child mortality rates. And the infant mortality rate for the U.S. is, okay, infant mortality rate, that's the number of deaths during the first 12 months of life per 1,000 live births. Okay, and then the maternal mortality rate, say that 5 times fast, refers to the number of maternal deaths per 100,000 live births caused by pregnancy or during the first 42 days after pregnancy. Okay, so you can see where the U.S. is 22nd in maternal mortality rate. So anyways, that is kind of high. I mean, 22 out of the U.S., I would expect us to do better. It seems like that is way too high for us and that we should be doing a lot better there. U.S. infant mortality rate for 2003 was 6.75. Low birth weight, late or non-existent pregnancy care often are some risk factors there. And then increased birth rate among the high risk group of adolescent girls and young women. So usually that high risk is women from 15 to 19 years of age. A lot of times they don't do the prenatal care. It could be they're trying to hide it from their parents, or they just don't have the money to do it. Child and adolescent health status. Okay, so technological and socioeconomical changes, communicable diseases of the childhood, morbidity rates among children often are associated with environmental and socioeconomical issues. Often it's because of poverty issues. Adult diseases occurring more often in children. And when you think about that, what are you thinking about? What kind of adult diseases are we talking about here? It's obesity is probably the first one that comes to mind. And of course, we have so many programs that are trying to get children out, get them out there, get them running, get them playing. Heart disease, things like that. Used to only see in adults, but now we are seeing in our children. So it's trying to empower them and get them moving again. Developmental problems. As we study pediatrics, we're going to talk through the different stages and the developmental milestones, what they should be accomplishing at that certain age. Educational support groups. We have Healthy People 2010, and we still do a lot of research from that. We still gather a lot of research from that and use that in our everyday lives and our everyday talks. You will see the nurse's role changing in maternal child health care as well. Image of nursing has changed dramatically. I think back to when they wore the white shoes, white pantyhose, white dresses, and the white cap. I promise you I wouldn't have been a nurse if we still had to do that. Just doesn't fit me very well. But now you see where men have come in and they've made nursing their own, and it's not just a woman thing anymore. You see where the nurses walk beside the doctors and are able to give them a lot of input to them, where that used to not always be the case. No longer do doctors really look down on nurses as unequal, or that they're so much superior, but they're kind of allowing them to come beside them. Most doctors, a lot of them are at least. Our role has changed from just providing the care to becoming teachers. Everything we do, we need to be teaching our patients. It's very important to provide that information and advice, make sure that it's correct and pertinent and useful to that person in need. And of course, we have to teach them on their level, so we're always trying to assess what that level is too. We have advanced practice nurses now. We have certified nurse midwives. We have family practitioners, nurse practitioners, neonatal practitioners, and pediatric nurse practitioners. You have school nurses, home health care, health teaching, critical thinking. All of these things go into being a really great nurse. Okay, and so we have discussed, or well, we haven't because this is the first time I'm seeing you or you're seeing me, really, but in class you have gone through the nursing process. You know what it is. You know that it's assessment, diagnosis, planning, implementation, and evaluation. And as you go through your nursing career, you're always going to use that. It never goes away. Even when you're out in the field, although you're probably not writing it down, this is my nursing plan, this is my assessment, this is my nursing diagnosis, you are doing it constantly. It's in your head. And right now, as you're a nursing student, we just want to make sure that you're understanding that process. And so that's why we have you do the care plans, which I know you hate, but it's so you can learn it and you can see it. Eventually, no, you won't have to write any of it down. You'll just know it. You'll have it in your head and you'll be able to work through it without working through it on paper. But as we're still learning, we're going to be writing it all down, and so we're going to be going through that. Documentation. We can never say enough about documentation. Over at the hospitals, they're actually changing their documentation a lot. They're completely computerized. Everything's electronic. They're moving away from paper, but you always have to make sure that your documentation is accurate and it's complete. And we'll get more into this later as we go along. Legal issues in delivery of care. Maternity nursing is the most sued area of all of the nursing areas. And why do you think that is? I mean, just think about that. Why would most people come and sue the OBGYN doctors? You know, here they are expecting this beautiful birth, this beautiful baby, and something goes wrong during delivery. It's not just the fact that their baby, their dreams, their hopes, all of that has been shattered, but all of that's been shattered for this baby. It's like that baby doesn't have the same chance at life. And so, of course, you can see where the emotions come from all of that. Okay, so we'll talk more through that as well. Chapter 2 we will do next.